I can tell we're in May. We're really excited to be toward the end of the school year. Lots of energy. Individuals will be taking their seats soon. I'm excited to kick us off for this year's annual share out about highlights in geriatrics. This is an exciting time where we will have 4 presenters, and depending on if we have time, we will share a video. If not, we'll share out the video that you all could watch in the email that comes out. So I'll just start with a couple basic announcements. We do have our next grand rounds, Jody Waterhouse on May 16th. What have we done by 2031? What will we have done perhaps by 2031 with the CU Multidisciplinary Center on Aging? Our next journal club will be May 9th by Zoom. Presenters are Dr. Sophie Clark and Dr. Devin Gilhooly, and it will be our final journal club of the year. So today I'll just modify a little bit in terms of evaluations. I'd love feedback just on this format, so help me plan it for next year. We won't be evaluating the particular presenters. Please feel free to give them kudos, send them email kudos. I really appreciate that they have willingly decided to share out some highlights for this year. So with that, we have 4 presenters today. I've asked them each to prepare up to 10 slides and take about 10 minutes. Then we'll have time for interactive discussion and questions after each presenter. Some need to run to clinic or to other things, so we'll do questions immediately after each presentation. And we will start with Dr. Ellie Cranky. I've asked each to also share just a brief introduction of themselves instead of me reading the bio. So Dr. Cranky will come up and I'll also get her slides rolling.
Hi, everyone. My name is Ellie. I'm a second-year resident here in internal medicine, applying for geriatrics this spring. I did a project, thanks guys. I did a project this year with Dr. Thais Bertazio, who unfortunately could not be with us today, but many of you probably know her as she will be a fellow here next year. And Dr. Lum is one of our lovely mentors. We also did this project with Ilian Mino. And it's called Development of a Resource Guide for Spanish-Speaking Patients with Dementia. Technologically challenged, okay. So in the United States, Latinos are projected to have the steepest increase in Alzheimer's disease and related dementias compared to other groups. And we know that they are experiencing more demanding and high burden caregiving situations, lower access to healthcare, and most of the resources that we have found are offered in English only or are challenging enough in English to navigate. And so we saw this need for our patients and their caregivers to be able to access resources in the community for loved ones with dementia in a little bit of an easier way. So in doing so, we did a bit of a literature review just to look up some guidelines for resource guide development and also sort of looking at how we can define burnout. I won't be talking much about that today as time is a little bit limited, but we did call more than 70 local agencies that provide services in many different areas. Asked them if they had any resources offered in Spanish, and then only ones offered in Spanish and ones that got back to us on a reasonable time frame were included in the guide. We did have a graphic designer that was able to help us with this. Unfortunately, I did not bring a sample with me today. But we then, after we formatted our guide, we were able to speak with caregivers in the community who are primarily Spanish speaking. Their loved ones are Spanish speaking, the patients with dementia, and then interviewed them on their experiences as caregivers and how useful they would find the guide. So this is an example of the table of contents. We did want it to be inclusive in English and Spanish, especially so that patients could see that these are the same resources being offered to their English counterparts. And then we did 6 interviews with different family members. All of them were women. We have quite a few other quotes, but wanted to be able to fit them on the slide. So some of the things that we heard from caregivers were that they're experiencing quite a bit of burnout. And many of them, despite having loved ones in the area, felt like they were the only ones willing and able to take care of their loved one with dementia. So these are some of the things that they said to us. And then all of them did tell us that the guide would be very useful and that they've never seen anything like it. And then some of us did tell us about experiences that they've had prior to the guide of trying to access resources on their own and not being able to access any resources that spoke Spanish. One of the bits of feedback they gave us is that it was a little bit challenging to navigate what the cost would be. So that is something that we modified in our guide. And so a couple of the conclusions were that we're still working on modifying the guide and running into a couple of things like different resources in the community change their cost models and whether or not they're even available on a kind of a rapid basis. So having a paper copy is a little bit challenging as we need to modify it quite frequently. We also learned a lot from our caregivers about just the depth of the burden that it is caring for their loved one, and that the majority of this role is for wives and daughters. We learned not unexpectedly that there are limited community resources, and it's even more challenging for this population to navigate accessing these resources on their own. And we're hopeful that our guide will be a good first step to connecting families with resources. And I'll take any questions.
Good job. How did you may have mentioned this and I may have missed it. How did y'all identify these 6 care partners?
Yeah, so we asked different physicians at the seniors clinic if they would be willing to, well, obviously first reach out to the patient's caregivers to see if they'd be willing to talk to us. And then we had a list of about 24 that we did contact. Some of them had their loved ones either they were back in their home countries already, and we just didn't know that in clinic, or were in a nursing home. And we wanted to focus on people who are caring for them at home. And there were 6 people that fit that criteria and also were willing to meet with us. Mm-hmm.
So I have a question. You developed this in the context of seniors clinic. Both you and Thais work in other clinics. What do you think would be needed, if at all, to have this be useful in other places?
Yeah, definitely. So I did present this at SGIM in the fall, and there were people there from Denver Health. Obviously, Denver Health serves a lot of Spanish-speaking patients. They thought that it would be very useful, and I think a lot of the providers were hoping for an online format. That being said, obviously we only were able to interview 6 people. One of them was a woman our age who's very tech savvy, but most of them liked the paper format and didn't feel as comfortable navigating the technology, but I think it would be helpful for social workers potentially to have an online format so we could more easily disseminate it to different clinics in the area.
Other questions?
And was this Denver specific or Colorado?
Denver, Aurora actually, but yeah.
Yeah, the question came up in a presentation of being able to expand this to Colorado Springs. So in the chat, yes, will this guide be available in the future for use when outreaching the Latino community?
Yeah, so I mean, we are one of the challenges that we faced was that even though we did this in a somewhat short time frame, the resources change so rapidly, which is okay. It just means that they're not going to necessarily always be as reliable every single month. Right now, I believe it's only really available in seniors clinic, but we're hoping to expand it as able. Yeah.
Wonderful, thank you.
Thanks.
We will now switch to online, so I'm going to unshare these slides. And I'd like to turn it over to Dr. Katie Nearing, who I think will be able to share her screen. Yep, that looks good, almost. And introduce yourself. Thanks so much, Katie, for presenting your work.
Thank you so much for the opportunity. Good morning. I'm Katie Nearing. I serve as an assistant professor in the Division of Geriatric Medicine and also an associate director for education and evaluation for the VA Eastern Colorado GREC. And I'm the principal investigator for a National Institute on Aging Research Infrastructure Award titled Workforce Development Engages Older Adults to Catalyze Innovative Approaches for Enhanced Recruitment and Retention of Older Adults in Clinical Trials. Before I share some of our successes from this initiative, I wanted to first establish the need at both the local and national level, as well as our overarching goal with this work, and then the opportunity created by the R24 funding. So in terms of the need, I anticipate that many in our audience this morning, whether you're a healthcare provider, a behavioral health interventionist, have experienced not having sufficient evidence to guide the use of new drugs, devices, behavioral health interventions with older adult populations, simply because those older adult populations are not sufficiently included in clinical trials. Recognizing this need, the NIH in 2019 put forth a new policy requiring the inclusion of older adults in clinical trials. Specifically, that policy required that researchers had to provide a clinical or scientific justification for age-based exclusion criteria. That same year, at CU Anschutz, only about a quarter of our adult clinical trials enrolled even one participant 50 years of age or over. When I examined the age distribution of that part of our research workforce responsible for doing most of the recruitment and retention of study participants in clinical trials, what I found is that fully 60% of this workforce were 44 years of age and under. Despite being the fastest growing age group in Colorado, adults 65 years of age and over make up less than 2% of our research workforce, and this has remained the case. So with this funding from the National Institute on Aging, our first aim was to train and promote the hiring of older adult research specialists to support recruiting and retaining older adult peers in clinical trials, as well as other underrepresented populations in clinical research. When I thought about these roles, I really thought about older adult research specialists fulfilling more of the community-facing and participant-centered roles that research study coordinators typically perform. So this included community outreach and engagement, facilitating the informed consent process, and addressing anticipated or emerging barriers to research study participation, so supporting retention in clinical trials. I also anticipated that older adult research specialists, by bringing their unique perspectives, lived experience to this work, would educate and train us in terms of how we could design our studies and implement those studies for inclusion, thus catalyzing innovation and positive change. So I'm going to profile a number of our older adult research specialists as I move through this presentation, and I hope you will see how they are helping to realize this initial vision. I want to mention too that not only are these older adult research specialists bringing transferable skills to this work, but they are also bringing their unique training and preparation to these roles, and that includes health navigation training, which I'd be glad to answer more questions about. So in terms of our accomplishments over the last 2 years, we have trained 4 cohorts. We have now 45 older adult research specialist graduates. We are currently training our 5th cohort, and it is our largest cohort of 16. The average age across our cohorts has been 68, with the range 56 to 82. And here you see more demographics about our older adult research specialists. To date, we have 18 older adult research specialist hires, and we have hubs that have emerged in geriatric medicine and neurology, and I'd love to see more hubs develop across the different divisions and departments, especially where a lot of aging-related research is happening. Before I leave this slide, I want to point to the title, that this is not just a job for these older adult research specialists, it's very much a calling, and I want to this passion for this work, I think, really comes forward in this quote from Debbie McKellop, who is a graduate of our very first cohort and a member of our Research Roadshow team. I just love my job. I'm very passionate about reaching groups of older adults in the subpopulations that are particularly underrepresented. This job has surprised me. I did not expect at this point in my life to be this excited and this committed to a job. I want to shine a spotlight now on Maria Jolly. She is a graduate of our Spring 2023 cohort. She's a research services professional in the Department of Physical Medicine and Rehabilitation Science. Her primary roles include screening and facilitating the informed consent process for studies focused on veterans with lower limb amputation. And she shared with me recently that every time she picks up the phone to reach out to a veteran about one of their studies, I am in for a surprise. And Maria brings forth her transferable knowledge and skills as an IT professional in the VA, which was her prior career, to helping veterans problem solve as they're moving through the e-consent process. And that's an example of those unique transferable skills really coming into play. One of the outcomes of the training that I did not anticipate is that it would pique the curiosity and the commitment of those going through our training to seek out opportunities to participate in clinical trials themselves. And this was certainly the case for Maria, who shared that I just recently finished a 9-month clinical trial that took up about 10 hours a week. And she said, I did it all. What caused me to stick with it, knowing we have trials that last 18 months. And so that integrity, we know, means a lot to veterans. I want to shine a spotlight now on Rich McClintock. He was a graduate of one of our original cohort, our first cohort. He is a research services professional with the Alzheimer's and Cognition Center on campus. His primary roles include community engagement and clinical trial recruitment. He most enjoys facilitating 2 community advisory boards, one of which engages Hispanic and Latino members of the community, as well as African Americans. His success story includes being promoted as the outreach and engagement coordinator responsible for all external partnerships and coordinating staff to participate in community events. He is also a member of our ORS consult service, so I'm going to use this as an opportunity to put in a shameless plug for our ORS consult service. This is monthly, second Friday. If you want to engage our older adult research specialists to help you problem solve and brainstorm ways to design for inclusion, please come visit us. These are the other members of that consult service. Now I want to shine a spotlight on Carol Willis. She is a graduate of our fall 2022 cohort. She is also a research services professional in neurology. Her primary roles include clinic-based recruitment, pre-screening, and designing recruitment strategies. And in these roles, she is applying her unique skills and knowledge as a communications specialist. And she really helps her team think about ways to really consider and be responsive to the whole person and the relationship building aspects and the relationship that we need to forge with our research study participants. And this is especially important as people maybe have just received a diagnosis and may be particularly vulnerable. And Carol has been recognized for her skills and knowledge and gifts, and has been asked to provide a department-wide training to share her knowledge and skills to make research more, if you will, human-centered. And then finally, I want to shine a spotlight on Faith Houston, who is a research services specialist in our division, working on an intergenerational team to recruit and retain older adults in a clinical trial. And she is part of a multi-site study with Wake Forest University. And Faith is bringing forth her skills. She formerly worked for FEMA, helping support communities after a disaster. And you wouldn't think that was necessarily a transferable skill set, but it is. I heard from Sarah Weary that there was a research study coordinator at Wake Forest who was really kind of stressed out about some situation, and that Faith really helped her calm down and brought perspective to that team. Faith is also a member of our Age-Friendly University Task Force and was a contributor to our built environment assessment. So an unanticipated outcome that I had not necessarily thought through or thought about is that ORS would be part of multi-site clinical trial teams. And in that role, Faith has certainly been a role model for teams at other sites or other universities, and is fostering interest in disseminating ORS nationally. So final slide to wrap up. I hope that with showcasing some of our older adult research specialist graduates, and there are many more I could have featured, that you're seeing how our older adult research specialists are fostering are advancing our age-friendly university priorities. And I will stop there. Thank you.
Katie, you are a leader in the country, so really appreciate you bringing this research and sharing your highlights here locally. We'll look for if there are any chat questions coming in by chat, you'll be able to see that. And then I also wonder, I'm going to go to Carrie Moreau.
Hi, Katie. I am just so in awe of what you've done with this program. And I've told you this before, that I think all of our coordinators that we hire, the young kids, should go through your program, because I think they're just so well trained. And I was thinking, even before you said this, of pairing one of these ORs with a new team of when we're kicking off a new clinical trial that's enrolling older adults, because I think they could learn a lot from the ORs. You know, sometimes a lot of the kids that we bring on are shy, you know, and they don't know how to engage and recruit older adults. And I just think they could just learn a lot from these ORs who just kind of, you know, just breathe this enthusiasm for research. So thank you.
Thank you for that comment, Carrie. And my aspiration with kind of ORS 2.0 is to actually redesign it as a multi-generational training program where we're pairing older adults who are pursuing encore careers in research with younger people who are pursuing their first career in research, so that kind of peer mentorship can happen within.
Oh, goodness. Hopefully she'll be back. But we agree with what she was saying. Have we lost all of Zoom or Katie? Anyone else?
We can hear, I can hear you,
Oh,
Hillary.
perfect. Thanks. Okay, so maybe it was Katie. Thank you, thank you. Well, please do follow up with Katie. Look into the Older Adult Research Specialist Consult. I have benefited from that consult service and proactively sign up. And it is actually not just about research for that consult. If you are designing a teaching program, a outreach program, a clinical program that you want to have the lived experience and perspectives of the older adult research specialists on the design and implementation of that program, they are a really engaged, knowledgeable group of folks. Yes. Hi, Kathy. I will transition us to our next presenter, who is Sarah Wary. So come on up, Sarah. I will shift things around. Find your slides.
Good morning, everyone. I think I know almost all of you, but I'm Sarah Wary. I'm an assistant professor here in geriatrics. I'm also a research health scientist with our Eastern Colorado GREC and Rocky Mountain Regional VA Medical Center. So I will be talking about an abstract that will be presented at the end of this month at the annual meeting for the American College of Sports Medicine in Boston. Maybe. There we go. So I think most of you who've heard me talk before know that I typically do biochemical markers of bone turnover. This study is a little bit of a departure from that. I did not study anything in the blood and instead did some imaging of some participants who participate in an exercise program. But just setting up some background for that. So older veterans do appear to be at greater risk for osteoporotic fracture than non-veterans. There is some evidence that women veterans have approximately 40% higher rate of hip fracture than non-veterans, and this is regardless of where they receive their care. So this is not just veterans receiving care at the VA, but anyone with a prior history of military service. For men, there is also some evidence that their bone health is impaired compared to non-veteran populations. We typically prescribe exercise as a means to maintain or improve bone health, especially into older adulthood. And there is some evidence that ground reaction force exercise is better than joint reaction force exercise, although there should be a benefit of both of these forms of exercise on the skeleton. And when I say ground reaction force, which is abbreviated as GRF, that is jumping exercise, walking, running. It's what it sounds like, where the force is coming from your impact with the ground or your gravitational forces. Your joint reaction force, or your JRF, that is also, again, what it sounds like, that the force on the bone is coming from the pulling actions at the joint. So this is going to be things like rowing, ergometry, or weightlifting. And studies in the past that have compared different forms of exercise to see the impact on bone have generally used DEXA and captured aerial bone mineral density. And DEXA is a great tool when you're assessing bone, but one of the challenges of DEXA is it's taking a 3D tissue and turning it into a 2D image. So you're losing a good amount of information about the structure of the bone and some other additional details beyond just how much bone is there. So while valuable, there are some limitations to this type of imaging. There are additional analyses. One of those is quantitative computed tomography that can capture volumetric bone mineral density. It can also generate some estimates of bone strength. So then the purpose of this study was to design this intervention to just get a sense of what is the magnitude of effect of the changes in things like volumetric bone density and estimates of bone strength after completing a ground reaction force or joint reaction force exercise intervention. So our participants in this study were 18 older veterans between the ages of 60 and 80 years old. They were randomized into either the ground reaction force exercise program or the joint reaction force exercise program. And they completed 26 weeks of exercise training, which is approximately 6 months. Exercise was 3 times a week, and each session was roughly an hour. We collected those quantitative computed tomography scans at the hip, which included the total hip and femoral neck and the lumbar spine, so L1 and L2, pre and post intervention. Our main outcomes were those changes in volumetric bone mineral density and finite element analysis, which is abbreviated as FEA, which is our estimate of bone strength. And for any of you with a little bit of an engineering background, this is a technique designed to assess the integrity of structures like bridges. So it's just an engineering technique that has been then translated into the assessment of biological tissues, in this perspective, bone. Within group changes were evaluated by pair t-tests. We did have a dream of doing between group changes to see if one form of exercise was potentially better than the other. We had a very low sample size, so those types of comparisons are not possible. So I'm not including them, not because I didn't want to, but because I can't really assess those kinds of differences. So in terms of our demographics of who participated, I think not surprising for this population, it was predominantly male and predominantly white, which is a very good descriptor of the veteran population in Colorado. Our average age was about 68 to 69 years old, and most of them were non-Hispanic as well. I put this descriptor next to this as a reminder of our intended sample size was 50. We obviously completed 18. We did not get close to what the goal was there. So all of these results should be interpreted with caution, that it may not necessarily be a lack of effect, but rather a lack of power, so that future studies, we have some sense of magnitude effect. So future studies can be powered appropriately to assess some of these questions. So in terms of our changes of volumetric bone mineral density, which is that first table there. So when we break down the sites that we looked at, generally speaking, if we look down the comparison between the two, with the exception here of the total hip, the ground reaction force does appear to be better than joint reaction force. This aligns with what we've seen in the data before, that ground reaction force does appear to be better in terms of generating a bone response versus joint reaction force exercise. Not really sure what was going on here with the loss in total hip with the ground reaction force, but this all may be indicative of sample size issues, large degrees of variability. Who knows if that would be replicated if done in a larger study. Going on to the finite element analysis, which is again that estimate of bone strength, and this is reported in newtons. So it's generating a force of how much a tissue can withstand in that moment. We're seeing a somewhat similar trend here, where for the most part, the ground reaction force is a little bit better than the joint reaction force in terms of the changes. I had forgot to mention before in the previous table, while these are showing increases, none of these are significant. So I can't definitively say that these are real changes. Moving into the finite element analysis, I did have one significant thing, which I think is a reminder, if you run enough comparisons, maybe eventually something will be significant. So in this case, seeming to have a significant change there. Just to give you a sense of what you're looking at here when we're doing our comparisons of the finite element analysis. So hip stance, stand out here to make it a little bit easier. So hip stance is we are loading the hip straight down at the knee. So as we're applying force down mechanically to see how much force that femoral neck can withstand. The hip fall is remodeling a fall to the side. So someone is falling onto that hip, and that is the direction of the force. For the lumbar vertebrae, it is pure compression forces. So just modeling straight down onto the vertebrae for both L1 and L2. So these are just giving a sense of general fracture resistance, of how much force can these individual tissues tolerate before they're going to go to failure. And we are seeing positive changes across all of these in terms of, quote, fracture resistance, even though, again, with the exception of the hip stance for the joint reaction force, these changes are not statistically significant. So in general, this study has provided some estimates of change to inform future larger trials, even though, again, our sample size was insufficient to compare changes between groups, and obviously probably insufficient to compare changes within groups. There is some evidence that there can be improvements, and there were improvements in both forms of exercise, which is not surprising. Again, both of these forms of exercise should be generated a positive effect on the bone. We're just somewhat anticipating that ground reaction force should be superior than joint reaction force based on the information that we have prior to this. I will say in the exercise interventions that I design now, specifically for improving bone mass, I use both. So all of my exercise interventions are really not purely one or the other. There is a component of joint reaction force and ground reaction force. This study also intended to explore potential sex differences, but the number of women participants we had was very low. So future studies should not only be looking to diversify the sex of the group, but also the age. This was specifically older adults, but there is some newer data coming out that younger veterans also have impaired bone mineral density. So potentially the need to start these interventions earlier to try to offset any deleterious effects to the bone as a result of prior military service. It's also important for these future studies to incorporate additional outcomes and analyses. So we used QCT in this study, which is into the CT scanner. They're scanned with a phantom. It is very high radiation. So there are some limitations to this technique in how frequently you can sample or what type of populations are able to undergo this kind of imaging. We do have a high resolution peripheral quantitative computed tomography scanner that we got within the last couple of years. This is much lower radiation. It will scan at peripheral sites, so usually distal radius and distal tibia. So much more reasonable in terms of who this can be used on and your ability to do repeat scanning over time. It also has the ability to do some additional analyses beyond what we're capable with QCT. But both QCT and HRP-QCT also have the ability to do what's called statistical shape modeling, which does require much higher sample sizes. But this gets at changes in overall bone geometry. So how has the shape of the bone changed, which could be interesting if you're thinking about hip fracture and you're trying to design a study and maybe the amount of bone there hasn't changed, but the way that the bone has changed in response to the load makes it more resistant to fracture, or that change is more clinically relevant. Again, giving us more information about how is bone changing in ways that we may not have been traditionally capturing. So finally, just want to acknowledge all the funding sources that help support this, and happy to take any questions.
Those of you on chat or on Zoom, please enter in questions and we'll get to you.
Hey, Sarah, so a hot topic in the aging world right now is exercise response variation. And I'm wondering, I know you won't be able to do this in your small sample size, but just in general, from looking at the literature, what is driving non-responders if they're doing the exact same exercise, but not responding to it? What could be blunting some of those bone changes? Are there influences of medications or just other factors that could be blunting that response?
Carrie, you baiting me to talk about the other arm of my research? So, I mean, a lot of it is we think about potentially anabolic versus catabolic responses to exercise, and there could be variation of some people have a more catabolic response that we usually try to get to in blood markers. Yes, medications can influence these. We screen out for a lot of the medications that we know influence bone at this point. We also try to screen out for a lot of medical conditions that influence bone. But if you're looking at a population just in general, we were doing an exercise trial where those types of things may not have been accounted for. That could definitely explain variation in the bone response.
I don't know if this was asked or just collected informally, but when you make someone do just the joint resistance force or the ground resistance force exercise regimen, do participants react differently to those different types of exercises? Like, it'd be very strange to me to go into a gym and just one or the other. Do people like have any strong feelings about?
Yes, so there are
regimens?
so there are definitely people who came in wanting more of a traditional exercise type of programming. We do fortunately have the GeroFit program. So when they finish this, we can send them into a more traditional exercise program where they can get what they were expecting. So we do ask them to just hang in there with us for about 6 months. I will say people are very compliant. We had about 83% compliance, and in terms of them showing up and also doing what they were supposed to do. But yes, there are definitely people who, especially in more the ground reaction force than the joint reaction force, were asking like, what do you mean I have to walk on a treadmill for 45 minutes and then jump around for 10 minutes and I'm done. And that was the end of my exercise.
Thanks, Sarah. I guess one thing that struck me was just in the beginning, the fact that veterans have a higher fracture risk. And I guess the things that came to my mind were environmental exposures or potentially like chronic stress. Any thoughts on that?
Some of the thoughts so far are definitely environmental exposures, chronic stress, nutritional deficiencies. So especially people who have been deployed and they're eating field rations, of what is the nutrient content of that, or if it's not very palatable, are they not getting enough nutrition for what they're being exposed to, especially in extreme environmental conditions where there's potentially a lot of sweat loss of different nutrients. For women specifically, there could also be the role of contraceptives, of being on contraceptives very long term, combined with all of these additional exposures, especially for the women who were studied, were serving at a much different time in terms of what availability they had for contraception while they're being deployed.
I have a question from Zoom, and then I think maybe, let me just pause. Christine or Linson, did you want to ask a question? Oh, sorry, Christine Swanson. I will go ahead with the Zoom-based question, and then Christine, if you did want to ask something. So question from Jason Hayes, is weightlifting typically prescribed as high weight, low rep, or low weight, high rep, so the two options. And does muscle hypertrophy with JRF versus GRF stress testing? You can also I'll also pull up the chat. Did you get the question?
So the short answer of how do we prescribe it? It's both. It depends on what study you're looking at and what population you're looking at. The studies that are coming out of Australia right now on weightlifting for bone are really preferring more Olympic style lifting. So very high weight, low rep. They've had very low injury rates. It seems to be something that can be done safely, but we do face a lot of resistance from the population of them not wanting to do that type of exercise. So right now it ends up being what you consider your typical resistance exercise training program, where they're going to be doing 2 to 3 sets of 8 to 10 reps. And that 10th rep should be to failure. So it's not something where they can continue going after they finish the 10th one. And in terms of muscle hypertrophy, there is some bone muscle crosstalk. So if there's more muscle mass available, it should be placing greater stress on the skeleton, especially in these weightlifting types of protocols. Whereas ground reaction force isn't so much the muscle as it is the impact with the ground.
Fabulous. Thank you. Great to be able to have this presentation locally. And really appreciating the discussion. We will transition to our next and final presenter, Dr. Dairagi. I'll pull up your slides. We will be sticking with the mobility theme and bringing it to clinic.
Hi, everyone. My name is Lee Dairagi. I'm also a second year internal medicine resident here at the University of Colorado. Also applying to Geriatrics this year. So the project that we submitted to AGS was a rapid qualitative analysis of medical assistance in the seniors clinic after successful implementation of the gait speed measurements in the rooming process. So we're going to talk a little bit about that today. Let me see. All right. So walking, as I'm sure a lot of you are very familiar, is a very complex movement that involves like cognition, motor, and sensory. And so it relies on a lot of pieces, and it is commonly shown to decrease with age. It has for a long time been used as a marker for mobility, but like for a long time now. It has been a validated and reliable measure for multiple health factors and has been kind of applied now to like overall health. Here you can see these are some of the things that it has been associated with. So now it's a validated predictor of like frailty, falls, functional dependence, cognitive decline, risk of hospitalization and institutionalization, as well as risk of cardiovascular events and all-cause mortality. So it's a very useful predictor, and then kind of note, it is also modifiable. And so gait speed has been shown that with exercises and things like physical therapy, we can improve gait speed, and in turn, by increasing gait speed, we can then decrease the risk of a lot of these poor health outcomes. So as you can imagine, it's very helpful to then be able to track this longitudinally. Gait speed theoretically is a very easy to measure and quick vital sign, essentially, that has been applied to multiple different sources. So we've used it in clinic, we've used it in research, in rehab settings, as well as home care settings. Yeah, so it's very useful if we're able to use it frequently. So in the seniors clinic, it's actually been set up, and we've been using it now for a while. This image on the right-hand side is of the gait speed device setup in clinic. I'm sure most of you are familiar with this. Potentially the MAs will walk the patient into the room and down this hallway. It's hard to see it in this picture, but there's like blue tape along the bottom. And so the goal is for them to walk between, there's two displays essentially at the far end, two sensors in the middle. And so like start at one end and just walk down this hallway, have their gait speed measured over this 4-meter walk test. And then they essentially just continue down this hallway into their room to see their provider. So after this was all set up, semi-structured interviews were conducted with 5 of the medical students in our clinic, using the framework of the questions that are here in orange to get a sense of what is positive about it, what's been negative, what are barriers that they have encountered, what has facilitated this process. As you can see, this process relied very, very heavily on our MAs, and they were key to the success of this and helping us to figure out what's been working and what hasn't been working, and so that we can make this reasonable. And so after these interviews were conducted, a rapid qualitative analysis of these interviews was performed by 2 reviewers, which is summarized here. So on the far left-hand side, we have the themes and then the topics and a couple quotes that we pulled out from these interviews. Overall, all 5 MAs had a very positive view of walking speed, measuring gait speed in clinic. They all reported that it's like helpful for patients. It can assess their overall health, and felt that it was helping patients to have poor health outcomes or walking speed impairments notified earlier and were getting referred to therapy earlier, and liked that they could track progress over time, and felt like the patients were also reporting that they enjoyed having direct feedback when it was measured longitudinally. Here's one of the quotes. There's 2 of the MAs even brought up a couple examples of when they had patients come back to clinic after they'd been enrolled in physical therapy, and noted that their walking speed had improved a lot, and were really excited about that. 4 of the 5 MAs specifically mentioned that the addition of walking speed into clinic was was a good workflow into the rooming environment. It didn't add significant time or work for them once it was established, that the automated devices made it very easy to do, and that they were identifying like when it was useful and when it was like reasonable to skip it, although most patients seem to be getting these measures done. And so all the quotes, they just felt like it was one of the biggest things they kept mentioning was that it's like in the workflow. So they just walk them down the hallway and then they go straight to the room, and it's not that hard. Some of the barriers have been addressed already. One of the biggest ones that was brought up in all these interviews was frustrations with the device. Initially with the temporary installation, it kept falling off the wall, was frustrating, would startle everyone. So that was one of the biggest things. A lot of the other barriers have started to be addressed. Some of the initial barriers that they noted were difficulty with patients following instructions. They would race down the hallway. They would stop partway through. They would veer too far from the wall so detectors wouldn't detect them, all of which would need to be repeated. It's also was noted that if their walking speed is too slow, the gait speed has like a minimum recording device, and so they won't be detected at that point. And then a couple other barriers were one of the MAs in particular noted that they didn't feel enough comfort with the knowledge regarding gait speed to talk about patients with it when they would ask all their questions. So helpful factors, a lot of them were things that specifically addressed this. A lot of the things got better just with time as patients and staff became more familiar with this. Putting down like that blue walking line on the bottom to keep patients close to the wall, having very specific instructions on how to guide patients through this I ease of EMR entry so that it didn't add too much time when they're entering it with the vitals. And then at least two of them, or I believe two mentioned that think that they found super helpful with this was also just getting feedback from providers in terms of how this has affected patient care. A couple stories where patients that they'd seen, like they noticed changes in their health because of the walking speed and felt that really encouraged them to continue to do this and help them understand why. All right. So gait speed has been successfully integrated into the UCH clinic, which is awesome. And the MAs were super crucial for the success of this. So we kind of went through a lot of the notable barriers and facilitating factors, but overall, a lot of them was like physical things about how to set it up to ease the walking path and all of that, different specific verbiage to use with patients, ease of EMR entry, using automated recording device instead of stopwatches. And then a lot of it was hearing patient stories and getting feedback and feeling like they were involved in their patient's care, which is awesome to hear. And then the notable barrier that at this point of these interviews was still being addressed was the permanent installation device, which seems to have gotten much better since then. So that is it. Thank you so much. Any questions?
Questions about this presentation? I'll ask a question. What do we know about patient perspectives on gait speed assessment?
Yeah, so some of the next steps that we're doing, I know we've interviewed a number of providers to talk about how this is working and impacted care in clinic. We just collected a bunch of patient surveys to see their understanding and motivation to address their gait speed, and motivation to participate in exercise and physical therapy if recommended. We are still analyzing that. Don't have any data yet, but overall, it seems that patients really like having this measured. So that's been true. The motivation seems to be very mixed, so we'll see what that pans out to be.
What recommendations would you have for another clinic seeking to implement gait speed?
Yeah, I think there is a guide that is in process to work to be able to share with other clinics to help this process. But based on this, having whoever is essentially doing the measurement, and in this case, it's the MA. So if it's the MAs as part of the rooming procedure for vital collection, working with them very closely and making sure that they're involved and have a lot of say has been huge. And just making sure that they're getting feedback too about why we're doing this and how it's helping their patients.
So are the MAs routinely sharing the result with patients? And are folks getting a sense of what that number means?
That is a great question. I don't know if the MAs are sharing the number with patients. I know there's certain patients who really enjoy knowing the numbers and have asked about it, and they are always asking and sharing and comparing it to their prior ones. With the survey, we're trying to compare like their knowledge, like what their gait speed is at the time that survey was done and what their knowledge of it is. And I'm still getting the data for that. It seems to be mixed about whether their knowledge, whether their understanding of their gait speed matches what it actually is or not.
It feels like it would be nice if at the end of the walk, there's what your number was and then kind of what that means in terms of.
Yeah. And it pops up on a little panel so they can see it. And then patients will get a handout that shows like red, green, yellow, depending on where they fall. How much they pay attention to that, I'm not sure.
I think one thing that stood out to me that you're mentioning was how the MAs were really excited to to talk to their patients about this. And like there was a lot of positivity from the MAs and feeling that they had agency in had an impact on their patients with this measure. What are your thoughts on that, and how does that make you think about burnout and things like that with our medical assistants?
Yeah, I really like that question. I think um, that also kind of ties back to especially the one interview in particular that brought up not feeling like they had enough information to share with patients. I think especially when there's these new factors implemented in clinic, the patients have a lot of questions and are asking a lot about it. And I think it's hard when you don't have the answers and you feel like you're doing something without getting the feedback. And so I think it definitely became clear that getting feedback on why we're doing it, having some basic knowledge about HB to share with patients. And then a couple of them brought up having resources like those papers and resources to provide to patients initially, especially where they're waiting for their provider, was super helpful.
I'll highlight a related comment from the chat that one of the older adult research roadshows included a tangible measure of gait speed. And that I think aligns with what we were just discussing here about how not just assessing it, but making it accessible and helping individuals engage with what the vital sign is measuring and what it means. And we had been able to optimize some of that through the research roadshows. Well, thank you all for a great discussion and participation online. We will make sure also that the older adult research consult handout gets sent out to all of us in the follow-up email. It was available on Zoom, but will also be available to all of us. Thanks so much. We have division meeting after this, but Stretch will reconvene at 8:30.